Yeah, good morning, everyone. Welcome to second day of Sing Life, track 1. This is session 13, a live case from National Heart Center, focusing on rotational or orbital atherectomy. So with me, my co-chair is Dr. Phan Mang Hong from Vietnam, and we have a distinguished panel from all around the world. Dr. Guo Wenyi from China, Dr. Jungo Hone from Japan, Upenta Ko from India, Dr. Kumar from the States, Richard Ng, our own Richard Ng from Singapore, and then our old friends, Dr. Ochi, I haven't seen you for a long time, from Japan. So we have our chat moderator, Dr. Phan Tuan Dat, which is our fellow with us a few years ago. So welcome everybody, and welcome the participant to the these sessions. So I think without further ado, we save time for the live case. So is the cath lab ready for transmission? Yes, we have Dr. Professor Yo KK and Dr. Wong Yen with us today. So KK, you're online now. Can you hear us?
Oh, because of the intro videos, is it?
KK, can you hear us?
Eric's hearing is worse than mine.
KK, can you hear us?
Yes, hi, Aaron. Good to see you.
You're live now. You're live now.
Okay, welcome to Sing Life 2022 and today's live case. My name is KK Yo from the National Heart Center, Singapore. With me is Dr. Wong Yen, who's going to work with me on this case, and Sister Tina here is supporting this case as well. Okay, we've got a tough day ahead of us, so I'm going to have Dr. Wong jump straight into this particular case. Dr. Wong?
Okay, so we have here today is a 68-year-old lady with diabetes, hypertension, and dyslipidemia. Some of the past medical history includes that of alpha thalassemia with a hemoglobin of 10, as well as mild chronic kidney disease. So she first presented to us late last year with heart failure and found to have a LV ejection fraction of 37%. Coronary angiogram was done, which showed heavily calcified triple vessel disease. So she was referred to the surgeons for consideration for bypass surgery. However, the pre-surgical workup showed that she has significant stenosis in both the superior and the inferior mesenteric arteries, as well as the left subclavian. Hence, she was deemed high risk for surgery, and hence the decision was for percutaneous coronary intervention. So next, as you see the 12-lead ECG, which shows a bit of T-wave inversions in the inferior leads, as well as ST depressions in V4 to V6. Next is a hemoglobin, is 10, and eGFR is around 50. Next, her medications. She was put on dual antiplatelet therapy in preparation for this PCI, and also she's on guideline-directed medical therapy for heart failure. Next, you can see her coronary angiogram of the left system, calcified diffuse disease of the proximal to mid-LAD, as well as the mid-circumflex. You can see some collaterals to the RPDA. After which you can see, today the target lesion will be that of the RCA, the heavily calcified subtotal occlusion in the mid-RCA with a bit of faint flow distally. It's very tortuous in the mid-segment, you can see in the RAO view.
So today we have already taken some angiograms. Now she came in with us with a bit of failure. And we put in a balloon pump prophylactically. And let me just show you the pictures of the right. And then perhaps the panel can provide some suggestions as to how they might want to approach this case. So let me take you through the angiogram today. Can you all see the fluoroangiograms?
Yes, we can see. Can you put the LAO on the main frame?
Okay, we'll put the LAO on the main frame. Is it good for you, Aaron?
Yes, yeah. So we see a very tight mid-RCA lesion and very severely calcified vessel. So can I have some opinion from Dr. Kumar? Yeah. So in this case, what would your strategy be for this case? Yeah.
So I think there's a lot of calcification in the mid-RCA as correctly identified. I think this is definitely a case that you're going to need atherectomy for sure. The issue is going to be what type of atherectomy you're going to be doing, whether it's going to be rotational or whether it's going to be orbital. I do not think this is going to be a great case for shockwave because I don't think you'll be able to cross that lesion with the shockwave initially. So at this point, one of the considerations is whether she needs a temporary pacemaker during the case. That's one more thing to consider, or preloading with aminophylline if you guys do that.
Okay, good comment. Dr. Wen Yi, in China, what sort of atherectomy device or whether shockwave is available in your country? You're muted, Dr. Wen Yi. Yeah.
Yes, yes. Because in our center, we still don't have a shockwave. So that's the first time I see the procedure about shockwave of yesterday, just you.
Okay.
So it's very useful, I think, for the severe calcified lesion. So and I just try in the TCT meeting I try the shortwave the things. So I think these things is good for this case. But I think maybe this case still can use ROTA. So we still want to, if possible, we need more try to this case. Thank you.
Okay. Dr. Ochiai, in Japan, you will be orbital, or would you use the rotational for this case? Yeah.
I think this region is very difficult to cross by device itself. So anyway, I first want to try rotablation.
Yeah.
And
so
shockwave is unfortunately still unavailable in our country.
Okay. So KK, I know that you're using a JR catheter. So
Yes.
with this very potential difficult case, is there a reason why you're not using unplugged? So?
You know, that's a good comment. You know, I generally, when for difficult cases, I generally revert to what I'm most comfortable with. And I think although it's difficult, I was a bit worried that if I do roto, the multiple bends will give me a bit of a headache. So let me show you what has happened. This is a 7 French JR4. We have put in a balloon pump, as you have seen. And I've also put in a venous line for standby for temporary pacemaker, given the length of this calcific disease. This is the AP view. You can see a faint shadow of the rest of the bifurcation and the vessels beyond that. Here I have a turnpike spiral, and this is a feeder wire. And you can see that we're right where the ostium is, and I think you can appreciate that the guide is being pushed out a little bit, as you correctly pointed out. Not the best supportive guide. Here we got lucky a little bit. The wire went through, I hope. No, not this one, this one. Oh, I think you have to watch this to the end. But we managed to wire with a regular feeder wire. We don't think it captured the whole thing. Oh yeah, here it went through. And then we were able to advance the wire distally all the way to the RPL. And then this is the turnpike spiral going through. So we were quite happy here. I mean, you know, quite happy. This is the rotor wire. But here we started having problems. It was very difficult to pull the turnpike spiral out. And eventually we couldn't get it any further. You know, we couldn't basically advance the wire any further with the turnpike spiral like this. And turnpike spiral couldn't be, pulled back without pulling back the wire. We tried all sorts of methods. So in the end, we wired the vessel sort of naked with a bare wire, with a rotor wire extra support, like this.
Bare rotor wire lah.
Yeah, so we wired it bare lah.
Okay.
So here we are with the rotor, and maybe I'll just, this is the new ROTAPRO 5.18, and it's got some unique features, and I think some advanced features which help us with the procedure. I'm going to let Dr. Wong take you through the components, and then we'll start the rotor. So Dr. Wong,
we can just focus here on the advancer.
Yeah, can you just go full screen on the screen, full screen?
Yeah.
And actually, we just had this new version of ROTAPRO just recently, and it's an upgraded version of there's no foot pedal. So Dr. Wong will explain the new.
I think the main feature, I guess, of the ROTAPRO is that there's no more foot pedal. Yeah, so everything to on and off the rotablader will be through this knob, and there's a button here. To on and off, you just press this button. Yeah, Dynaglide button is now here. It's not the foot pedal. Yeah, and you can temporarily activate the Dynaglide through this button here. So that takes away the foot pedal completely, and everything is all on this Advancer system. So it's a lot more convenient and a bit less coordination. Maybe we can just focus on the console here, over here on the left, on the right here. I think one other thing about this new change is that the console, now is a lot sleeker. Yeah, it's actually can be mounted on this IV pole and not have to be on a trolley. So you don't have to keep pushing here. If the patient is sick, it's all on this slim trolley. And the digital analog is a lot clearer and big. You can see the RPM, the numbers are fleshed out, the event time, the procedure time. And actually there's a big space there. If there's deceleration of 5K RPM or 10K RPM, it will show as a triangle. So it kind of warns the operator if you're decelerating too much. So everything's a little bit simpler with less coordination and more intuitive.
So I think that's some very useful developments for the technology, which has been around for several decades now. So we are today. This is the current state. I'm ready to start burring. My typical speed is 150. So we're going to start. Okay, so this is we're watching the pressure. Nitroglycerin has been given. Fluoro is on. We're going to turn it on at 150. Not much of a jump. Very good, stable. Slowly, a touch of deceleration. Leave the wire. So we're just going to go slowly because I'm mindful that the wire is not very far in.
Okay, while KK is doing the burring, can I just ask Dr. Kumar, in the US, the Impella, this is considered definitely a high-risk case. So would you have put in the Impella in this case rather than an IBP?
Not necessarily. I think at my center, we do a lot of atherectomy, and a case like this, we would probably do without an Impella.
What about IBP? Would you have put an IBP in for this case? EF is about 35%, I think, yeah.
Probably not either.
Okay.
I think one of the reasons to put in a balloon pump for this lady is that yesterday when she was admitted, she was actually in the heart failure, actually. We had to diurese her, so we think that the heart may be a little discompensated. So just to be on side of caution in this lady.
Yeah. It also depends on the LVEDP. If you have a LVEDP up front, sometimes that helps. If you're starting out with the LVEDP, it's already 25, 30, it's putting in an IABP is a fantastic idea. So I think Dr. Yeo is definitely on the money by putting in an LVEDP, putting in a IABP. At least there's some kind of support in the event that things don't turn out as expected.
Yeah, Dr. Pham, in Vietnam, in this case, would you put in a IBP for support, or you would just proceed with the PCI with the Rota?
Yeah, thank you. So it is a very high risk in my center. We usually put in IBP or standby.
Okay. Yeah. Dr. One, obviously you love to have imaging for this case, but the thing is, I don't think anything will go down in this case. Would anyone try to use a small balloon to have a pre-dilatation to see whether any imaging device can go down?
No, I don't think so. Yeah, because in this case, the pre-imaging is not so important, and probably this very tight stenosis, we need rotabrator anyway.
Yeah. Okay.
So after rotabrator 1.25 bar, then image, and then we decide which strategy or size up or change it to the orbital or so.
So in this case, because there is difficulties crossing the lesion, so the orbital may not may not work in this case because you have a nose cone that
Right.
may not cross the lesion. So in this case, I sort of totally agree that the rotablation is probably the only way that may get this through. The other option is, I'm not sure anybody have experience with laser, excimer laser. I think in Asia, probably not so common. In the States, Dr. Kumar?
Some of my partners would do laser in this scenario. At the center that I work, we do not have a laser either. But we have, Aaron, as you may know, we have some experience with RotaShock that we have used in this kind of scenario. In fact, we have published our first US experience of RotaShock a few months ago. And this is an ideal setup for RotaShock, where you start out with a small burr, like what KK is doing. And then you take a shockwave balloon on top of that. Obviously, this is not a very cost-conscious strategy. It is an expensive strategy, as you very well know.
Yes.
In our center, we use the laser for this kind of severe. We do not so much, but some experience.
Okay, so how is the result? Does it work most of the time, or it's the success rate to cross this sort of lesion with laser?
It's quite good for some. Sometimes the burr doesn't work. The laser is works.
It's working. Okay, I think it's good to have this sort of backup device that when nothing works, then it may help. Yeah, Richard, you have any comment on this case? It looks
Aaron, thank you. I think so far I've been quite impressed because I thought it was very difficult to cross. I just wanted to ask Aaron, whether they spend a lot of time using wires or just a filter and micro cath was able to cross quite easily before the camera.
Yeah. So I think there's some.
So Aaron, something has happened.
Yes. Yeah, we saw. Yeah.
Do you see what happened?
No.
Yeah, the
Just watch
wire broke. Yeah.
It's not the wire broke. The cable broke. Yeah. So this presents a bit of a problem. While y'all talk about what to do, let me just get a few things going. The 1.7 thing.
Sorry, what? Sorry, is a cable broke? Which cable? I mean the one.
The cable connecting the burr to the catheter has broken.
Give me a. Okay, so typically when this happens, that's obviously not very good. See whether you can. Okay. We're going to put a bit of Dynaglide here. Okay. We'll talk for a while. Save that. So the good thing is that the rotor wire has a gap, a step up in the what do you call it, the diameter. So that allows us to backstop against the burr. So here what we'll do is we'll just take out the system, but I want to make sure that everything is stable first. Test for me.
So is the cable that connect to the burr actually broke, right? So
yes.
Yeah. So I mean the burr is, the head is dislocated lah.
Yeah, put everything out. Why?
Yeah.
Okay. But the burr is still on the wire, and so you know he's able to, because the tip is larger, he's able to withdraw it. We have had this problem before, so he should be able to withdraw it and come in with a different system.
Okay.
Okay, hang on for a while. See the top, please. So while you all discuss, about what I should do next, we're going to just get some equipment ready to take out the whole system.
Yeah. So I think sometimes when you do the burr, when the guide support is not good, the forward force for the burr may not have enough to force the blade. So maybe I would suggest to change the guide to a more support guide to an AL. Maybe have a better success rate. Sorry, Richard, you were saying just now that you would try to balloon it with a small balloon first, or
no. Yeah, that is also one option. What I was wondering is how KK they all had got through the wire quite easily. It seems just with a filter and micro cath.
Yeah.
Did they try a few times? Do you know before camera with other wires? Because this looks like a very difficult lesion to cross with the ordinary sort of wires that we have.
Yes. So KK, was it hard to wire the
yes. It was hard to wire.
Yeah, it looks like almost a subtotal occlusion. So yeah.
That's again.
A lot of calcification and also long lesions and also several areas. And as you have mentioned, it was very difficult to support the right. So I'm very impressed that with the JL4, they could actually cross seemingly quite easily and getting onto rota.
Yeah, wire a bit.
Yeah. So KK, I think this guy is really not giving a lot of support because look at it, the way it hangs. So yeah.
I mean, I hear you. It's just that I'm a bit not so fond of the AL guides.
Okay, yeah.
And
so I think the main part is over, as in that we already managed. So that's why now the wire goes through fairly easily.
Yeah.
So let's see whether this microcatheter goes through easily. So my question to the panel is. Should I roto again? Or no? So let me take a picture here now that we have things under a bit of better control. We'll take a picture and then you guys can tell us what you all would like us to do. So obviously it's still very calcified. Yeah, and you can see the trough made by the previous roto. So
I think
what do you guys
the main
think?
lesion still hasn't been rotobladed yet, so I'm a bit worried that part may not expand.
I feel the same thing. Let's give me a new roto extra support again.
The panel agree with continue to rotoblade?
Yes.
Yeah.
But the microcatheter now easily pass through the region, so I suppose we should use 1.5 millimeter burr.
Okay, 1.5 millimeter burr,
Yeah.
Dr. Ocha, I think that's a really good idea.
And a little bit, I think, more RPM. I would like to start with 200,000.
Dr. Ocha, I've never mastered that art of it.
Yeah, 200,000 is officially the upper limit proposed by Boston, so you don't need to worry.
I know.
I love maximum, but I always start with 200,000, and after 3 or 4 times of passing failure, I switch to maximum.
Yeah. So let me just go around the panel. So what's the RPM that you usually use? For myself, I learn for OCI, I use 180, and if it doesn't work, I go up to 200. Dr. Pham?
Very good.
Dr. Pham?
Thank you. So I still thinking that the guide is not support very well. So if we're moving on to 1.5 mm, it may have some difficulties. So I also think that we have a 2 strategy to use a low rate and high speed rate for rotablation. In my center, usually we use a low speed rate for ablation for some kind like this very severe calcification.
So it's about 150 or 160?
165. Yeah.
Okay, Wen Yi?
We still need high speed.
High speed.
Maybe yeah. So, almost we use the 60 to 80.
Okay.
If couldn't pass, we get the 222 or more.
Or more. Wow. Dr. Honey, you think that it makes a difference, a low speed and high speed?
Yes, probably I start with 180 because using lower speed, it takes time to cross the lesion with ROTAPRO, and sometimes patient gets ischemic. So I recommend to start with 180 or even more.
Even more. Dr. Kumar, you have your experience?
So in our experience, Aaron, I'm the same as you. I would probably start with 180 RPM. And probably, if it's having difficulty, I'll go up to 200,000 RPM. Now, the reverse is also true. In my final run, I will actually go back down to 140 or 150 because in our impression with the higher speed, you tend to actually remove the wobble of the device and you tend to actually go straight in and out. And so when you actually slow down the speed for your final run, for your polishing run, you can actually get a little bit more ablation by slowing down the speed for the final run.
Yeah, that's a good comment. Yeah, that's a good comment. Richard? Yeah.
Sorry. No, I'll follow what Dr. Ochai said, what all the panel have said. I think I would probably feel that it's kind of like to start with 1.25 again and at higher speed. But I think the point that, at 1.5, you might be able to have a more stable entry down the calcified lesion.
Okay.
Platform. Table above 160.
Yeah. So KK, you're taking out the 1.5 burr now, right?
Yeah. Okay, good. Let's go. Okay, we're going up again. Okay, sister, ready? Okay, we're going up. So we gave more nitro. I think that was, it's good to pay attention to the shaft when we do the burring. Ready? You got it?
Yeah. The other concern is the because it's such a long lesions and so calcified. So whether anyone who put a temporary pacing wire prophylactically in this case?
Yeah, I routinely put the temporary pacemaker in case of RCA rotablation without any exception.
Cool.
Yeah. It's very simple. Just take 5 minutes.
Dr. Kumar?
We've kind of gone both ways. We've done a temporary pacer and we've not done a temporary pacer. I think KK has got a great strategy. He's got venous access. In the event that he needs to put it in, he can put it quickly. I think that's a reasonable strategy.
Okay.
But I agree with your point. It's a long lesion. It's going to require a fair amount of rotational atherectomy.
Yeah, Dr. Fan, routinely you put a pacing wire, or I don't myself because for me I don't usually or just like to get it through, and then when it's through I just pick up the very short procedures. Yeah, so I usually don't. Yeah.
No, for me I usually for using standby, not routinely use a pacemaker. Yeah, just standby. Yeah.
Okay, I think they cut off the sound because the rotablation sound is a bit noisy. Yeah.
Can you hear me? I think it's a very good discussion. But here we are 1.5 burr going down the proximal to the mid right now. Can you all hear me?
Yeah, we can hear you. Yes. Yeah. So
I noticed that the heart rate has come down a touch, but it's still good. Stand by some dopamine.
Yeah, so the different technique of doing sort of burr. Some people just do a woodpecking sort of type of thing, just in and out. Some would just put it at the lesion and then drill and then pull back. Long contact time rather than short contact time. So I'm just wondering whether any panel have any comment on this, whether any advantages or disadvantages of this pecking.
I don't use pecking technique anymore recently. I slowly push the rotablator because the most terrible complication is bus stuck.
Yeah.
So I slowly push the rotablator for 10-50 seconds and then stop. Slow, but one session is very short. Instead, RPM is very high. I think this is the safest way to do rotational atherectomy.
Yeah, Dr. Hone, you agree with Dr. Ochai?
Yes, I agree with Dr. Ochai, and the slow movement is very important. And so especially in this case, this patient has very poor ejection fraction, so that we want to minimize the particle to the distal peripheral vessels. And the slow movement and control the rotational speed is very important, especially in this case.
Okay. Wang Yi and Dr. Pham, any comment on the technique?
Yeah. In special case, we maybe try to slow the
Stand
speed.
by covered stance.
But mostly just
Dopamine can start.
Yeah.
Okay, so KK have went down to mid part, still haven't crossed the lesion. And the small tap
Aaron
that
and,
they was outside any time.
Aaron and panel, there's a big trough and the pressure is a bit borderline. So I'm actually going to stop and just make sure there's nothing surprising. Okay, let's walk it out. Okay, yep, liner glide is on. So the let's have the Mizuki after this.
Did you try to use
2-5 balloon? Okay, stop, got it.
Is it possible to show the hemodynamics? The OB band? Is there any feed for the hemodynamics? Yeah, here you go.
Let's just start at 10. So I guess on I suspect that there is probably some form of perforation, but I don't want to do anything until I've got my equipment in. A 2-5 balloon to trap and a fresh 2-5 balloon for tamponade. Stand by a pericardial drain. So, you know, this obviously can happen with a rotational atherectomy. And that was what we were worried about going in. BM? Yeah, BM/W wire for me, please. Hang on, I don't pull out yet. There's still a lot of calcium basally. Okay.
Do you have a CT image of this case?
Run some fluids for me.
I don't think there is any CT image for
CT image.
I don't think so.
You don't think so?
Yeah, we don't have a CT.
When I watch the fluoro, heavy calcification is seen until the end of distal bifurcation. So I suppose we should do rotor up to more distal part of RCA. But of course, you can stop here, but I think it's essential to check some imaging device.
Yeah, so because the blood pressure is dropping, so a bit hypotensive, that's why the KK stopped here. Yeah. So there is some at the proximal part, they worry about perforation. Yeah.
Yeah, you know, when the vessel is like this, I think we have to be very careful. And I think, you know, since we have gotten the initial part okay, we have a bit of a window. 2-5 balloon to trap. Walk this back a bit. So it's a good thing we had the balloon pump. I pushed a bit more wire. Hang on there. Right.
If blood pressure is now low, why not inject a small amount of contrast?
Yeah, I think that's a good idea. I will do that right after this. Balloon down. Okay, step back a while, please. Let's do a picture here. Okay, so there is a big trough, but fortunately no perforation, but there's obviously no reflow. Let's give me a 1-5 balloon first. So here, I think we have to change strategy a little bit because obviously with the no reflow and the borderline hemodynamics, we do have to adapt. I think Dr. Ochai's point about more rotational atherectomy is a good one, but let's see what we can do with a 1-5 balloon, establish flow first, and then we can decide what to do next.
Yeah, KK have to be careful because you see the outline of the RCA.
Yes, there's a big trough.
So be outside the calcium chunk.
Yeah, I know. So I'm not going to balloon that part. I'm going to balloon the mid onwards.
So because I think you used the extra support wire for rotablation, so wire bias was very strong. So rotabar actually ablated the calcium in media.
Okay. Yep.
Yeah, so if you can, I would like to see IVUS, especially proximal RCA.
So this is just a 1.5 balloon. I think we can do that, but maybe I'll just do a bit of ballooning first because I want to make sure there's good flow, just to protect the flow. Give me a 2 balloon after this.
Yeah, KK, absolutely.
Yep.
I think getting some flow down the vessel at this point is critical.
It's just a 1.5 balloon now. Just save a test for me, please. So yeah, flow is a bit better now, I think.
Yeah.
We have a bit of breathing space. Let me do a bit more with a 2.0 first, and then I'll do what Dr. Ochai wants and give the images. 2.0 balloon.
So while you're doing that, KK, maybe you need to adjust the inotrope to get the blood pressure a little bit.
Yeah, we started 10 mics of dopamine already. We can go up a little bit.
So take some questions from the audience. Yeah. What are the complications may occur with higher speed? Dr. Ochai, what's the downside of having a higher speed?
Sorry, Charity.
I don't fear any dark side of high speed.
Okay.
Up to 200,000, I don't think it's high.
16.
It's regular.
Okay. All right. Any other comment from the panel? Yeah. And the other question is, what do you think the mechanism of the burr head detachment? So I think the possibility is that because of the calcium, the burr got stuck in the calcium and the machine still spin. Yeah, so maybe that's how it break off the head. I think that's the most likely cause. Yeah. Any panel have any other explanation for this, Dr. Pan?
That's for me. Okay, good. Just give me the IVUS.
Okay. Another question is, can I know if anyone will pre-medicate with norepinephrine or put in a temporary pacing wire? We talk about it. And what type of calcify in what type of, yeah. So is there any RCA calcified lesion that panel will just put in the pacing wire straight away? I think Ochai mentioned before he'll put in for everyone because it's a simple thing to do.
Yes, yes. In case of RCA rota, I put the pacemaker in all patients.
Yeah. So aminophylline, I don't use it often myself. Dr. Kumar, it's a routine or?
So Aaron, I have a partner who uses aminophylline for his cases routinely. I tend to take the same approach that KK is doing, which is, I tend to have for these kind of long lesions where I need to do plenty of rota runs, I tend to have a venous sheath available so that I can quickly put in a temp pacer if required. Now, if it's a very long, complex lesion in a patient who's borderline unstable,
could you make
okay.
So we're doing the IVUS now, and maybe Dr. Wong can take us through it.
Just now we are pulling back from the mid segment of heavily calcified. Now we are.
Maybe we'll let it finish and then we'll do it again, yeah? So whatever this is heavily calcified, there's a mega trough there. I think we are in the proximal right. And coming back to the ostium. So the only thing I'm worried about is that proximal right, if I were to balloon it, whether the thing will perforate, yeah? That's certainly a consideration. Okay.
Maybe you do a manual run on that, right? Yeah.
Yeah, live.
Okay,
I can't go any further down.
IVUS, yeah.
I go to the trough area.
So this is the area of the trough, huh?
You can see at 9 o'clock.
Okay. So in this area, the rotabrator was working very nicely, especially in 3 o'clock. But however, basically the vessel size is very big, and in this case, the guide wire bias is not so good because the IVUS catheter is now attaching to the healthy air segment. So in terms of proximal right coronary artery, the guide wire bias is not so good, and try not to ablate the proximal right.
Okay. So it's still within the vessels. Yeah, it's just of the wire bias.
Yeah, so Aaron, I mean, the pressure is better, but of course, I'm not happy about it. We're just going to balloon and expand the distal first, and then we'll decide whether we should use a shock wave. Can I ask the panel, what would you do? Would you further pre-treat the proximal right with another balloon? There's of course a risk of perforating. I've done that before with a balloon, but what do you think? Tell me what you would do. 25 NC. This is
So Aaron, maybe you can educate us a little. What are your choices for covered stents in Singapore? Do you have papyrus, or what do you have on the shelf?
We have V-graft, papyrus. We have as well. Yeah.
Okay. I think it is probably reasonable to go ahead and balloon dilate that proximal vessel. It looks like a large vessel. At least balloon dilate it to have an idea of whether your balloon will give, so that when you stent it eventually. You have, I think your strategy of taking a 2.5 NC is reasonable to say, hey, I want to balloon dilate it and see whether it can expand, because you're going to have to stent that proximal vessel to cover that area as well.
Okay.
Yeah,
so
I think
this balloon wouldn't go down any further. 16. It's an NC. 16. Wait.
Yeah, so I think we probably need to fix the proximal part first, and then we can deal with it the later part, because it's a very huge dissection at the proximal part.
And that's a very nice balloon assisted tracking that KK has done there by advancing the guideliner. Very nice technique.
By the way, what size stem would you choose for the proximal right?
What did the IVUS show?
Good question. 20.
20.
Okay, we'll look at it in a while. Huh? No. A tiny waist, but I think it's acceptable. Okay, test for me. Okay, test first. Looks very scary, I must say. Huh?
Yes.
I'm actually not going to do too much ballooning here. Otherwise I have to do more than what I'm doing. Okay, just maybe the ostium. Okay, up here.
I'm just thinking what's happening here is that is that a pain perforation, or is a huge dissection?
I think it's a dissection.
Yeah.
Well, actually, rotablation ablated calcium mainly around the
inferior area,
inside the plaque, very close to external elastic membrane.
So maybe we'll take a look and see what length it got. Oh, wait.
Maybe this is an old lady, so it's reasonable to put the 3O stent and then check IVUS, and we should decide.
Give me a 3O strategy. Give me a 3O 33 stent.
My impression is 3O stent.
Yeah. So get one that can expand much wider, so that if it's bigger, then you won't undersize it.
What do you think of I'm going to use the Firehawk here. I think it's got a pretty good expansion profile. I think this one can go to the 3. I think can go to 5.5, or if I remember correctly, or 4.5. So I think we'll start with that.
So you probably have experience with this Firehawk stent in China.
Yeah.
Oh. I mean, it's pretty radio opaque. Thin strut, I think it's 85. Cobalt chromium. Reasonable, pretty good deliverability. Conformable. And with the guideliner, I'm able to get it down.
Yeah.
Okay, so we're now in position. I'll have Dr. Wong test very carefully, of course. Test. The problem is that I don't dare to inject too hard because of the dissection.
Yes.
Test for me. it may not be that easy to get the osteoma test again.
So KK, we have about 5 minutes, so it's fine. Just take your time. Patient safety first. Yeah.
Yeah. That's okay.
In relation to the dots on the balloon, where is the stent mounted for the Firehawk? Because we don't have Firehawk in the United States. It's undergoing US trials right now. So where's
it's within the marker. I think it's within the marker. I mean, it's different from the Zion where it's mounted just at the marker. Yeah. So the most important is in this case is to secure the proximal part, and then establish flow, adequate flow, and then we can deal with the distal part later on. Yeah.
Oh. Nominal is
10.
Okay, 12, 14. 14 hemispheres. Okay, wait for a while. Down. We're down.
Yeah, you can see that the stent is unequally expanded. Yeah.
Up here. Give me a 3-5 NC down.
Yeah, so we'll let you post dilate, and then we just see a final angio before we leave you, before Dr. Pham give a conclusion for the thing. So
okay.
Before we lose you, we thank you KK for doing this very complex case. As you know, the rotablation, it comes with the risk of complications. I think you handled this really well. The situation. Dr. Pham, you want to make a conclusion for this? Yeah.
Thank you, Dr. Thank you, Dr. Wang. So we all know that cerebral coronary artery calcification is still challenging in our field of interventional cardiology. I think the good preparation for calcification lesion is the vital step for our intervention. So by this case, we would like to thank the Professor KK for very comprehensive case and the team. I think this case is very good demonstration of the using and some tip and some tricks and some facing to the some situation during the case. Before closing, I would like to thank all the panelists for their discussion and contribution. I would like to close this session right now because of time. So see you. Thank you.
Yeah. Thank you, everybody. Yeah.
Thank you.
Maybe we will post the results of the final angiogram on the website for everybody to see what actually happens. Yeah. Okay. Thank you.
Thank you. Thank you. Bye bye.
Goodbye.
Thank you very much. Bye bye.
Bye.
Thank you.